on-call medical handover is a process that happens with or without supporting tools to make sure that shift to shift there is a safe transfer of information from one doctor on call to the next doctor on call. So that might be, and between regular teams as well. So you can think of it, during the day there's a normal ward team. At 5 o'clock they go home, they're going to hand over to the evening doctor who's on for another 4 hours. Then they're going to hand over to the night doctor for 12 hours, their 12-hour shift. And then that night doctor might hand over to the Saturday day doctor, and so on and so forth until you resume normal working hours. So that can be a good 6 shifts or something that this information has to be consistently transferred over for safe patient care. And if you don't have that safe transfer of information, if things get lost, if we don't realise, if we forget that a blood test needed checking or that wasn't communicated clearly, then there could be a serious patient safety incident. So we need to have that safe transfer of information, and often digital tools can really support with that. Every hospital, every team does it differently, but usually there are some kind of digital tools involved nowadays. So that might be emails between colleagues, or a standardized system with a standardized template, and that's what the RiO handover was, just a standardized part of the electronic patient record where you can go and find all of the on-call handover tasks and the patient details that the task is relevant to, so that we could keep track of, has that task been handed over, has it been actioned, is there anything still awaiting, what's the update for the usual day team doctors.
And the big advantage was that it was already on the system that we used for clinical notes of patients, so it wasn't a separate system, which was what we were using before, like something separate from the digital system of record keeping. So this was everything all in one, which is a huge
in the patient record,
advantage. Yeah.
Another lesson for us was about how zooming out this type of project might be really useful in other teams as well, because it's not just the inpatient on-call medical shifts that need this kind of handover. Basically every clinical team has some kind of handover system, because you're not necessarily the same professionals working every day. People take leave, and especially for acute care, liaison care, crisis care in mental health, handover is really important. So we were thinking about how we could kind of disseminate our learning about building a tool in RiO, because RiO is the most widely used electronic patient record within mental health trusts, and there are, when you build a digital tool, it can be helpful to make a kind of blueprint for other trusts using RiO, that they can build exactly the same thing and use in the same way. And obviously that takes the sting out of it, because we've already done it, we know it works, we can give them a ready-made product, so to speak. But not just within RiO, so as well as other teams within our own trust, potentially teams beyond our trust could benefit from the tool.
Can you tell me a bit about some of the work that you both did on the project?
Yeah, so essentially we had to meet up quite regularly with the whole team. We had weekly meetings also with Ash, our IT team member, and we would meet to kind of come up with how we would do the system, how it would be on RiO, which is what we use, the digital system we use, and we would kind of speak about ideas of how we would like it to be. And we were resident doctors both. Yeah, at the time it was both, and then Hussein joined. We were working the on-call, so we knew exactly what needed to be on the medical handover and kind of how we wanted it to be, a visual, how the visual should be, and yeah, so that was our involvement of giving our own feedback and having the meetings regularly with IT.
Yeah, because I think if Ash had tried to build it in isolation without that input from people who've really done the process, really used done the medical handover tasks and used other handover systems. So we have the expertise, subject matter experts to be able to feed in on any prototype he builds, provide feedback and a new iteration of the tool. I think without that feedback from real users, it's quite hard to build a tool that is fit for purpose. And obviously we couldn't build on our own, having no experience of building the tools in RiO, so Ash was really helpful and vital for that.
Okay. And can you tell me what the end outcome for the project was?
Yeah, so we met from kind of early or mid last year, 2024, and then we had mocked up a prototype by about kind of late 2024. We got some thoughts of resident doctors, which we'll talk about when we talk about how we engage doctors, and then we did the pilot in January, where we tested it on one inpatient site, and then the full rollout across all 5 inpatient sites was March this year. So since then, we've been kind of checking that everything's running smoothly, fielding feedback and requests for little tweaks, and the main part that remains for us now is to write up the QI project.
Okay, lovely. And I think you kind of referenced it earlier, but you talked about how you engaged staff in the project. Can you tell me a little bit more about that?
Yeah, so essentially we kind of always wanted to have, so we were resident doctors, so we knew how it was, what we needed, but we also wanted to involve all our colleagues and peers who are also going to be using the system. So we initially got some thoughts from them, and we spoke with them about it, and got some ideas off of them as well. Then we used our academic program to speak about the project, to kind of warn people, the system is going to change, we are working on it, what would you like as well, and kind of, do you have any feedback for us? So we used the academic program. We also used to send them emails with kind of then the guide that we put together of how to use the system, the user guide. So we sent that over, emails, and then we also had surveys to ask people what they were thinking of the system, what they felt needed change, what was better, what was not working. So we also always gave our emails as well, and were kind of open for people to reach out to us, which they did. They would send us emails when something wasn't working. So we kind of had loads of ways on how we engage with our colleagues, and I think it was quite successful in that sense.
Yeah, I think when it comes to engagement, I think a really important piece is meeting people where they're at, because if you try and set up separate webinars and just send an online invite to a meeting that people don't know much about, they don't really know enough to carve out that time in their day to go and find out necessarily. Everyone's busy with clinical work. So it's much easier to meet people where they're at, go to a space where they'll already be, or try and tack it on to the end. So for resident doctors, that's the academic program. Going to a place where people go, a space that is protected for learning about new things, and a place that people already have carved out their schedules, then you can either go into that academic program, or second best, I think, is tacking it onto that existing slot, because then people are already in one place together. So that's what we try to do. We try to do kind of maybe monthly academic program attendance up until the rollout, and then a couple times after rollout as well, as an opportunity for Q&A, so that any teething issues could be worked out and troubleshooted.
How did you engage with senior members of staff in the project?
So I think we were really lucky with this project in that there was already that quite senior buy-in and commitment from the start. The call came from the ex-CCIO, Chief Clinical Information Officer, Dr. Loreen Hanna, who was one of the doctors working with the digital team, with IT teams, on this kind of project. And it was I think, identified as a risk that the clinical information of patients was being kept on the Microsoft Microsoft Teams handover, because keeping patient information in lots of different places isn't the best approach to information governance and clinical standards. So that we were approached as saying, who wants to take hold of this project and run with it, and here is an IT colleague who's willing to support you with it, and that's what we did. And we also had Selim Levison, who kind of took over from Loreen in giving us that senior support going forward. So any times we had kind of, for example, circulating the comms is not just to the users but also to clinical directors and other senior clinical leadership, so that they know changes are happening. And for example, we also needed to loop in other IT colleagues, so there weren't too many IT go lives at the same week or month. So getting senior support is really helpful for things like that. Otherwise you end up hitting barriers to your project progressing.
Great. And can you tell me, were there any challenges you encountered along the way in your QI project?
Yeah, I mean, there are always challenges in projects. I think we engaged well with our colleagues. I think they engaged well in the project and with us and all of that. But the survey, we hoped we would get more responses in the feedback surveys, considering all the people that are using the system, because it's not only core or higher trainees, it's also trust doctors and specialty doctors. So anyone who's working on calls that they might not work specifically in this trust, in jobs in the trust. So they also kind of use the system. So we didn't, I'd say we didn't get as many responses as we'd like, even though we spammed a bit our colleagues. So I'd say that was one of the challenges. Another one was, as you were saying, having to bear in mind that there are other IT projects going live. So we were planning on launching it one date, and then no, we can't do it. We have to delay it a bit more, and kind of arranging when the best time, so we wouldn't be overwhelming our colleagues with loads of new systems and ways to work, because it takes a learning, a bit of a learning process to get around all of those systems.
Yeah, I think some other challenges is that because it's an IT system, it's not like we could design it exactly how we wanted. We're constrained by what RiO will let us build as the electronic patient record. So we did have to kind of be a bit flexible with how we were going to get round some of the quirks of the system. And actually a lot of that was through good communication and good support through the user guide. So things that we were just unable to change, because it would be like a change request to the RiO company, which would take months and months to come back and might not even be approved by them and might cost extra money and so on. We had to find workarounds by just explaining really clearly to the user inside the form why certain things don't work as intuitively as you might like them to, and how to make sure they work every time. So, things like using red text saying you must click this button and then that button, was some quirks we had to deal with and work around.
So can you tell me a bit about any learning that you've taken from the project?
Yeah, it's been actually really nice to see how the project came out and how we're using it at the moment in the trust. The fact that we're all using the same system for medical handover in all the boroughs of North London, for medical handover in patient wards, and I think that was a good learning point in the sense that we had this, the idea came before we joined the project, but there was this project. Obviously we didn't know if people were necessarily going to like it or be a bit grumpy about it, but turns out that people are using it. they like it so far. Obviously, it's not perfect because we, as you said, we cannot change everything that we'd like because it's not up. We can't change sometimes some of the things in the software, but seeing that people like the system, that it's easy to use, it's quite intuitive, and actually make things easier because it's, you know, the patient's there, you can click on it and it goes directly to the patient's page. So all of those things just make life and work a bit easier in that sense. And it's quite, you know, we built this tool and now it can be applied to several different areas, and it can be quite long lasting handover system, quite sustainable in that way, I'd say.
I think for me, getting the right people in the right room would be a big lesson, because actually, like I said, we were really lucky that was kind of set up for us. We were the resident doctors, so we were the subject matter experts because we used the handover, but we already had an IT colleague whose time was available for regular meetings. We already had a senior colleague who was going to support the project. And I think as part of that, having CCIO or CXIO resource is really helpful, because they're a type of clinician that works with digital teams, works in the digital team to support digital projects, but with a clinical understanding. So they're kind of a bit of a middleman that has clinical experience, but also has experience of IT projects, and they can bring both of those areas of expertise. And that was really helpful to have that support from both Loreen and Senem, who were and are our CCIOs in the trust. And since the project has finished, I've also taken on an associate CCIO role in the trusts, but I also have some preceding digital experience, so I could bring that to the project. I think that helps you do things like have flexible workarounds when the system says no, you can't do that. How do you kind of make it as good as you can, and then communicate to the users what they need to do for their workarounds. I think the other lesson is that, you know, we're told when we're setting up a QI project that you need to get buy-in, that's really important to get that from the start, and I can't emphasize that enough. I think if we hadn't had CCIO support, then we wouldn't have been able to do things like get the right people in the room, because we wouldn't have that IT colleague who could commit some time to it. I think if you don't go senior enough with your project, consultant or team leader, manager, maybe clinical directors even, then you won't necessarily, you will hit more blockers on your project. And I think if I was setting up a project from scratch, I would keep in mind I need to escalate it senior enough to get that support and buy-in. Or on the flip side, if that's just not something I can necessarily do, I'm not senior enough to turn those cogs, then I might instead be a bit more opportunistic, jumping on a project that already has senior buy-in, which is effectively what we did. We didn't get that buy-in. We saw that it was already something that had legs for the trust and had that senior buy-in, so we just jumped on the bandwagon.
Yeah, and also I think a good learning point was having, so we started beginning of 2024 more or less, and the pilot was essentially launched January the next year. So it was 1 year where we were meeting up quite regularly, like every week. We had weekly meetings, and also via emails we would exchange, something had to be said in between meetings, and having that consistency, throughout the year kept the momentum going, and not like delaying things further, because it can get quite, if you leave it 2 weeks, 3 weeks, kind of forget what has been done, what needs to be done moving forward, so it can get everything a bit like delayed. So I think it was time consuming. I mean, you had to work around your clinical hours and every home visits, I remember at the time, so it can be quite time consuming and take a lot of organizing your schedule, but it is necessary in order to get something done, and a project like this done. It really, a learning point that you need the consistency to be there.
Yeah. I think at the moment our main goal is to keep that momentum going for the QI write-up as well, because I think we're all struggling a little bit with the QI methodology of how we process the data and how we present that for things like conferences, and so that is our last hurdle, commitment that we need to make to keeping up that momentum for the write-up, which is maybe the less doing bit but the studying bit that we need to see it through.
Great, thank you very much, both of you.